Okay friends, so we will discuss about the calcitonin. Okay, so calcitonin is secreted by a parafollicular cell. Okay, secreted by a parafollicular cell, C cells of the thyroid gland. Okay, all knows that there is a thyroid gland. Okay, and okay, so on the thyroid gland there are the parafollicular cells. Okay, parafollicular cells which of C cells or C cells, parafollicular cells called C cells of the thyroid gland is secretes calcitonin. Okay, calcitonin is secreted in response to rising or high level of plasma calcium ion and acts to lower circulating level of the calcium. Okay, calcitonin is secreted when there is a high level of plasma calcium. When the calcium becomes high, the calcitonin is secreted and act to lower circulating level of the calcium, and it will lower the calcium. Okay, then calcitonin acts on kidneys to inhibit renal reabsorption of the calcium. Okay, so basically calcitonin acts to decrease the calcium in the body. So on the kidney, what will it do? It inhibit the reabsorption of the calcium and phosphate. Okay, not only the calcium, also the phosphate reabsorption will be inhibited by the calcitonin in the kidney, and on the bonds to inhibit bond resorption by osteocytes. Okay, it also inhibit the bond resorption by osteocytes, because due to after osteocytes the calcium will increase in the blood circulation, so bond resorption will also inhibited. Then we will discuss about the calcium handling. What is the calcium handling? So normal values of calcium and rationally for corrected calcium value. So RCEM defines the normal value of total serum calcium as 2.1 to 2.5 millimole per liter. Okay, this is the sum of 3 ionized calcium and sum of free ionized calcium and the calcium bound to the albumin. Okay, it's not only free or bound, it's sum of free ionized calcium and calcium bound to the albumin, which is 2.1 to 2.5 millimole per liter. Okay, it is total serum calcium. This total serum calcium measurement must be adjusted for albumin level, as patients with the low albumin have total serum calcium lower than the reference range, yet have normal free ionized calcium, and vice versa. The total serum calcium measurement must be adjusted for albumin level, must be adjusted for the albumin level, as patient with low albumin have total serum calcium lower than the reference range. With low albumin, the total serum will also low as compared to the reference range, yet have normal free ionized calcium. Yet have normal free ionized calcium, whether the free ionized calcium is normal, but due to low albumin the total serum calcium will be low. Okay, and if the albumin will be high, whether the free ionized calcium is normal, the total serum calcium will be higher than the normal range. Okay, 0.02 millimole per liter should be added to the calcium concentration for every gram per liter. Okay, 0.02 millimole should be added to the calcium concentration for every gram per liter that albumin is below 40 and 0. That albumin is below 40. If albumin is below 40, 0.02 millimole per liter should be added for every gram per liter. Okay, every 40 gram per liter, if albumin is low, 0.02 millimole per liter will be added, and 0.02 millimole will should be uh, minused. Okay, for every 40 gram per liter of albumin increased. Okay, got it. Then corrected calcium is equal to measured calcium plus 40 gram per liter minus albumin into 0.02. Okay, measured calcium plus 40 gram per liter minus albumin into 0.02. This formula should be memorized. Okay, then calcium absorption. So calcium rich food include cheese, milk, yogurt, fish and some vegetables and nut. Cheese, milk, yogurt, all the milk products, fish and some vegetables and nuts. Okay, fish came, then vegetables and nuts. Of dietary calcium, about 25 to 30% is absorbed by gut. Okay, of dietary calcium, of all dietary calcium, about 25 to 30% is absorbed in the gut. Calcium is absorbed throughout the small intestine, but mainly in duodenum and proximal jejunum. Okay, mainly in the, this is the, sorry, so this is the stomach, then we'll start the duodenum. Okay, this is the duodenum and the proximal jejunum, okay, here and here the calcium reabsorption will occur mainly. Okay, absorption occurs by transcellular process involving intracellular calcium binding proteins called calbines. Okay, absorption occurs by a transcellular process involving intracellular calcium. Absorption occurs by transcellular process involving intracellular calcium binding protein called calbines. Gut absorption is increased by activated vitamin D. Okay, transcellular process involving intracellular calcium binding protein called the calbines. The absorption will occur by this protein, and gut absorption will be activated by the vitamin D. So that's why I'll tell that for calcium absorption we should also add vitamin D with that. Okay, then physiological action of calcium. What is the physiological action of the calcium? So calcium is essential for enzymatic reaction, then intracellular signaling. Okay, enzymatic reaction, enzyme, then intracellular signaling, then nerve conduction. Okay, nerve conduction, then skeletal, cardiac and smooth muscle contraction. So basically the contraction of skeletal muscle, cardiac muscle, and smooth muscles. Okay, the release of neurotransmitter. The release of neurotransmitter. Okay, neurotransmitter. Then the release of hormones. Okay, the release of hormones. Then secretion from exocrine gland, secretion from the exocrine gland, blood clotting and bone mineralization. Secretion from the exocrine gland, blood clotting and bone mineralization. Blood clot, then bone mineralization, secretion from the exocrine gland. Okay, these all are the function of the calcium. Okay, enzymatic reaction, then okay, then intracellular signaling, then for the nerve conduction, then contraction of the skeletal muscle, cardiac muscle and the smooth muscles, then release of neurotransmitter, then release of hormone, secretion from the exocrine gland, then the blood clotting and the bone mineralization. Then transport of calcium in blood. Transport of calcium in the blood. So what happens in this, that only unbound ionized calcium is physiologically active. Okay, so only unbound ionized calcium is physiologically active. Free intracellular calcium must be maintained at a very low level. Most is bound to protein or stored in the endoplasmic reticulum, and mitochondria must be maintained at a very low level. Free intracellular calcium. Okay, blood calcium level in the extracellular fluid are kept within a very narrow range to maintain normal physiological process. Okay, so basically it should be at the very low level, free ionized, and the extracellular fluid containing the blood calcium level also should be within very narrow range. About 45% of the serum calcium is bound to albumin, about 5% is complex to other ion, and about 50% is free ionized calcium. Then ionized calcium, so ionized is 50, complex to other ion is 5%, and 45% is bound to albumin. Then ionized calcium binds to negatively charged site. Okay, ionized calcium binds to negatively charged sites on protein molecules, competing with hydrogen ion for the same binding site on the albumin and other calcium binding proteins. This binding is pH dependent and alter the level of ionized calcium in the blood, and increased in pH alkalosis promotes increased protein binding, which decreases the free calcium level. Acidosis on other hand decreases the protein binding, resulting in the increased free calcium. Got it? Ionized calcium binds to negatively charged site on the protein molecule. Okay, negatively charged site. It compete with hydrogen to bind on the protein molecules. Then this binding is pH dependent. Okay, and alter the level of ionized calcium in the blood. So if increase pH is increased or becomes alkalosis, it increase the protein binding calcium. So the free ionized calcium will be decrease, and if the acidosis is there or decrease in the pH, the protein binding will be decreased, so free ionized calcium will be on higher side. Then renal calcium handling. So what happen in the renal calcium handling? The calcium that is not protein bound is free filtered. Okay, the calcium that is not bound to protein, it's freely filtered. Okay, in the glomerulus, and there is reabsorption along the nephron. Free filtered in the glomerulus, and reabsorption will occur in the nephron. About 70% is reabsorbed in the proximal tubule, and 20% is reabsorbed in the thick ascending limb. Okay, so will be absorbed in the glomerulus. Then there is the proximal tubule where 70% of calcium will be absorbed, and then in the thick ascending limb, sorry, this is the descending. Here thick, here is a thin, and here is a thick, there is a thick. So here, from here, the 20% of the calcium will be reabsorbed. This reabsorption is mainly passive and paracellular, and driven by sodium reabsorption. Sodium reabsorption causes water reabsorption, which raise tubular calcium concentration, causing calcium to diffuse out of the tubules. Okay, so how this calcium reabsorption occurs? So it passively it is passive diffusion driven by the sodium reabsorption. If the sodium will be reabsorbed here, so if sodium increase, the water will be increased, and the calcium here in the tubule will be on higher side. So it will coming out by the diffusion, Okay, the positive lumen potential also encourage calcium to leave the tubule. The positive lumen potential will also encourage to leave the tubule. About 5 to 10% is reabsorbed in the distal convoluted tubule, and the 5 to 10%. Okay, this is the ascending limb, and from here there is the distal convoluted tubule. So 5 to 10% will be also reabsorbed in the distal convoluted tubule. Less than 0.5% is reabsorbed in the collecting duct, and from here this is the distal collecting, there is the collecting duct. So less than 0.5% is also absorbbed from here. Then calcium reabsorption is in the distal nephron is active and transcellular, and is the major target for hormonal control. So in the distal nephron, this calcium reabsorption is active transport and transcellular, and is major target for hormonal control. Okay, so regulation of the renal calcium handling. Regulation of the renal calcium handling. Okay, the calcium homeostasis is primarily controlled by the hormones, parathyroid hormone, activated vitamin D, and the calcitonin. Calcium homeostasis is primarily controlled by the three hormones: parathyroid, vitamin D, and calcitonin. Parathyroid hormone acts on the kidneys to increase the calcium reabsorption in the distal tubule by activating the calcium entry channels in the apical membrane, and the calcium ATP is pumped in the basolateral membrane, and to decrease the phosphate reabsorption in the proximal tubules. Okay, how parathyroid hormone will cause the reabsorption of the calcium. So it increases the calcium reabsorption in the distal tubules, as we have seen earlier, by activated calcium entry channel into the apical membrane. As we have seen that there is the apical membrane. Okay, this is the lumen and the outside the apical membrane. So activating calcium entry channel in the apical membrane and the calcium ATPase pump in the basolateral membrane. Apical membrane have activating calcium entry, okay, and the calcium ATPase pump in the basolateral membrane, and to decrease the phosphate reabsorption in the proximal tubule. Then activated vitamin D act to increase the calcium reabsorption in the distal tubule via activated basolateral calcium ATPase. Okay, as we have seen earlier, the activated calcium ATPase in the basolateral membrane pump, and to increase the phosphate reabsorption will also increase the phosphate reabsorption, and the calcitonin act to inhibit renal reabsorption of the calcium and phosphate. Calcitonin have negative effect. It will inhibit the renal reabsorption of the calcium and phosphate. Okay, parathyroid hormone will increase the reabsorption of the calcium and decrease the reabsorption of the phosphate. Activated vitamin D will increase both reabsorption of the phosphate and the calcium, and calcitonin will decrease or inhibit the reabsorption of the calcium and phosphate.